Our next speaker is Dr. Sadaf. She's consultant radiologist at Noori. She is a nuclear medicine physician, crossed the line, and now she identifies herself as a radiologist. And she has come up with a very interesting title, Correlative Nuclear Medicine Imaging with CT and MRI. I believe she will be bombarding us with a lot of CT and MRI images alongside nuclear medicine. Dr. Sadaf.
Thank you so much, Dr. Zahir. Bismillahirrahmanirrahim. Assalamu alaikum. So yes, I'm a radiologist and nuclear physician working in Noori Hospital. And I'll be focusing on correlative nuclear medicine imaging with CT-MR. And that is the cross-sectional imaging, the cross-sectional anatomical imaging, how it can complement the nuclear medicine imaging. So this is a beautiful sunset image taken while coming to Faisalabad on 23rd October. So a nuclear medicine scan, we have a finding in nuclear medicine scan. It raises or gives a list of differential diagnoses. And then we do a correlative imaging. And the purpose of correlative imaging should be to narrow down the differential diagnosis, to reduce the differential diagnosis and come near to the diagnosis. So obviously, when two imaging modalities, the physiological one and when the anatomical one, when they fuse, they give superior diagnostic performance. ये auto run कर रहा है, is it? Okay. Mistake. Okay, and whenever the CT component or the CT is added as correlative imaging modality, there is always dose concerns and there is increase in effective dose to the patient. So I'll not go into the theoretical details of clinical applications of SPECT CT or PET CT and everything. A lot have been already covered by the presenters. In oncology, I would like to say one thing in oncology and neurology, that MR is excellent in correlative imaging in neuro for brain lesions and also for locoregional staging, that is for pelvic tumors. MR is superior to CT for T component of the TNM staging. So these are other more commonly used applications of cross-sectional imaging. I will jump to, I have brought a few cases, few interesting cases where the cross-sectional imaging or the CT and MR, it helped in reaching the diagnosis. So the first case, this is a 59-year-old female patient. She was known case of recurrent papillary CA thyroid, and the tumor was inoperable, and her tracheostomy was done, and ablative dose of iodine 131 was given. Here you can see the linear uptake in neck, and then you can see that this iodine 131 uptake in the mediastinum or in the extending into the chest. And when the correlative imaging was done, you can see that there is iodine 131 uptake in right paratracheal location, and then lower down, when you come lower down, you can see this uptake into the chest, and you can accurately see that on CT, you can see that this uptake, this iodine uptake is in superior vena cava. So here on post-contrast CT images, you can see the primary tumor that has infiltrated into the trachea, this, the tracheostomy tube, sorry. Yes, the tumor extending into the trachea. And here you can see that the thrombus is itself enhancing on post-contrast study, the thrombus in the superior vena cava. So when a thrombus is showing post-contrast enhancement, it is showing On iodine 131 post-ablative scan, it is showing uptake. It is a tumor thrombus. So this was basically a tumor thrombus from papillary CA thyroid. Here you can see again the enhancing thrombus. Here, the superior vena cava, and it is extending up to the lower down. Next case. This is a 58-year-old male patient who was diagnosed case of DLBCL of right testes, and he had bone marrow infiltration positive on biopsy. Post 6 cycles of chemotherapy, and no obvious previous imaging was available. His PET CT scan showed a faint, you can see this faint uptake in right axilla. And when the cross-sectional imaging was done, you can see this focal uptake in intermuscular plane between the deltoid muscle and the infraspinatus muscle. So this is a very uncommon location for a lymph node to present at this site. And if you see at the CT component, here you can see the central part of the lesion. It's not enhancing. There is peripheral post-contrast enhancement, and the central part was giving HU of around 13 to 14. So this was a fluid collection with surrounding post-contrast enhancement. So we gave it as inflammatory uptake. However, the clinician was not satisfied. They proceeded for FNA, and it came out to be inflammatory cells. So it was given Tufail X. Some authors say that Tufail X is a new tracer uptake on PET when it is not related to lymphoma. So it is not in standard Tufail scoring, but some of the authors say that Tufail X can be written for any new uptake that is not related to lymphoma, a benign uptake. So next case, this is a case of a patient that presented with a carcinoma of tongue, and she underwent a staging bone scan, and you can see there is intense tracer uptake in right parietal bone. And when her CT component was taken, sorry. So when the CT component was taken, you can see that there is expansile lesion in right parietal bone, and it is giving ground glass appearance. There is no destruction of overlying cortex. The lesion is not a destructive lesion. So this is a typical appearance of fibrous dysplasia, and radiologically, you can say even from the radiology images that this is fibrous dysplasia. We have her MR images, although these MR were not done for this skull lesion. This was done for the lesion in tongue. So here you can see that there is no destruction of the cortex. It looks very benign, and there is no post-contrast enhancement. And the lower images are of diffusion rated, and there is no diffusion restriction. So this patient also had a focal uptake in costovertebral junction. And on cross-sectional imaging, you can see that this was a non-metastatic uptake. This was arthritic. So this is a case of Hodgkin's lymphoma, a 14-year-old patient who had extensive disease, extensive mediastinal lymphadenopathy, hepatosplenomegaly, involvement of both liver and spleen. There were para-aortic abdominal lymphadenopathy, and there was involvement of the bones as well. Here you can see all the lesions, abdominal. When the brain images were seen, here you can see there is relatively low uptake in left parietal lobe, and there is a lesion which is giving faint FDG tracer uptake. This FDG tracer uptake was less than the corresponding normal brain parenchyma on left parietal lobe. So on left side, it was the uptake was 6, and on left side it was around 6, and on left side it was 5.6, and on right side it was 6. So it was relatively lesser than the normal brain parenchymal uptake. If you see, then the MR imaging was done. The CT images, it showed radiodense lesion in left parietal lobe, and there is out of proportion edema around the lesion. And when you look at the MR images, the upper one is the T1, and the second one is the T2, and the lower one is the FLAIR image. And you can see that this, the lesion has out of proportion edema, and the post-contrast images show that it is showing intense post-contrast enhancement. So radiologically, the lesion is in favor of a metastatic deposit. Now, the Hodgkin's disease very rarely metastasizes to brain. It is very rare for a Hodgkin's lymphoma to have intracranial mets. So the clinicians proceeded with the biopsy of the lesion, and it proved to be a deposit of Hodgkin's disease. So MR was very good in interpreting this lesion. This is another interesting case of a patient. This was a case of Hodgkin's lymphoma that was treated, and then his LDH level, there was a slight rise in LDH levels. The patient underwent FDG PET, and you can see in this case that there is a focal uptake in left lung. The correlative CT image, you can see focal uptake in left upper lobe. However, there was no anatomical abnormality seen on CT correlate. So this was sometimes in some of the cases when there is uptake in a lung and you do not see any abnormality on correlative CT imaging, it can be the cause can be an iatrogenic microembolus that can also give rise to this kind of findings. And this PET scan was repeated after a week, and it was normal. So this was a benign finding, and it should not be mistaken for a metastatic disease. Obviously, it would change the whole scenario. Okay, this is a case of mixed germ cell tumor of testes. He was operated in 2012. Then he had a second malignancy of he had left nephrectomy for adenocarcinoma in 2022. This patient has this CT appearance. There was a cystic lesion in left paraortic location. You can see here. I'm not using the pointer because the slides start moving. So the other lesion you can see in the pelvis, in front of the iliacus muscle. So this, on FDG PET, you can see that there was very faint uptake, which was equal to the background uptake in liver. And the lesion in front of the left iliacus muscle, it did not show any FDG, it did not show any FDG uptake. So it was taken as metabolically inactive disease. So after 6 months, this patient came up with a large enhancing component in left paraortic location, and you can see in this scan there is FDG uptake. So there was progression in the disease. And when you retrospectively look at it, yes, there was faint uptake, but it was less than and equal to the background liver uptake. Here you can see the other lesion that was in pelvis, in front of the left iliacus muscle. It is now also giving faint FDG uptake. So another case of carcinoma of left ovary and high-grade mucinous adenocarcinoma, and this patient underwent PET scan post 3 months after staging laparotomy. Her TAH, BSO, and omentectomy was done. You can see that there is uptake in the omentum. And when you see at the CT images, there is considerable uptake in the omentum that is more than the background uptake in liver and mediastinum. So if you look at the CT component, if you look at the details, although there is post-contrast enhancement around this uptake, but if you look at it closely, you can see that there is fat inside this contrast enhancement. So you look at the density of the fat of anterior abdominal wall and look at it is in the center. So this is basically an omental infarct, radiological appearance of an omental infarct. And an omental infarct sometimes give delayed uptake on FDG PET. So it should not be mistaken for omental deposits. So it is a benign uptake. Okay. I will go to the last case. Yes, this is I will hurriedly go through the case. This is iodine 131 post-ablative scan. Here you can see focal uptake in pelvis. And on CT correlate, you can see that it is in sigmoid colon. And here you can see there is a diverticula in the sigmoid colon, and there is perilesional fat stranding. So this was diverticulitis, a benign uptake. And the last case, this was a case of left-sided parathyroid adenoma which was surgically removed. And after removal, there was again a rise in parathyroid hormone levels. The parathyroid scan showed a focal uptake at lower pole of right parathyroid gland, and then you can see that there was adenoma recurrence. So this was the last case. The CT and MR are obviously they are for anatomical localization, but obviously the radiological characteristics, they add to the diagnostic value of this hybrid technique. And whenever you add CT component, there are always dose concerns, and the risk versus potential benefits, the benefits versus potential risks should be weighed, and there should be dose optimization in each case. And obviously the planar imaging results should be seen with history and clinical question captainment, then should be proceeded with correlative imaging. So thank you very much.
Thank you so much, Dr. Sadaf. I hope this is the last slide, right? You want to say something?
I wanted to thank the organizing committee for inviting me and for giving me the opportunity to be part of this forum. And thank you very much.